Good afternoon, and welcome to When Lions Speak, Why Don't Systems Act? This started as an idea that was shared as an email. It became a conversation, and we're here today. Thank you so much for taking time out of your busy schedules to participate in this important discussion about health inequalities during Black History Month. So this event has been curated by the Department of Nursing, Community and Public Health in partnership with CIMI Scotland. My name is Judy Wasige. I'm one of the lecturers in the Department of Community Nursing and particularly in the public health area. I worked really closely in curating this event with my colleague Monique here. Monique is the Program Manager of Communities and Priority Groups at CIMI, and Monique and I share a common interest in community engagement and have designed numerous events together, so it was a real pleasure working with you in curating this event. Okay, this is a Black History Month event, and therefore the focus of the event and the discussions today is going to be around anti-racism. While there were emblems of hope for a post-racism society coming out of the pandemic, it's becoming increasingly challenging to watch what's happening on our streets. Yet we had really important lessons that demonstrated that there is more that unites us than divides us. By taking an anti-racism approach, the objective of this event is to lift the conversation from being personal to recognizing that racism is systemic and that it requires collaboration and learning to challenge institutional hierarchies that perpetuate racialization and racial inequity. To enable conversations that need to happen to address it, it becomes then important that we begin by naming racism first, with the view that we can actually begin to consider how we can address it. And for this event, we use Professor Kamara Jones' definition of racism as a system of structuring opportunity and assigning value based on the way a person looks. This unfairly advantages one group while unfairly disadvantaging others. The net effect is to sap energy out of the whole community, and that's why it's important that we have these discussions. Focusing on health, this event acknowledges 3 key interventions that have been used so far to address health inequalities. Firstly, it's about ensuring access to healthcare for all, and the NHS is testament of that achievement. However, as we listen to the case studies today, let's question if there's always access to services available for everybody, particularly for adversely racialized communities more specifically. Secondly, there has been increasing awareness and intention to address the social determinants of health since Sir Michael Marmot and his team pointed out that access to healthcare alone was insufficient in addressing health inequalities. However, his review 10 years later demonstrates that for all the recommendations made on the original Marmot review, the country is going in the wrong direction, and consequently, health inequalities have worsened. This calls us to question why adversely racialized communities consistently have poorer housing, poorer employment, and poorer life opportunities. Thirdly, there is increasing evidence to show that societal structures, particularly historical power structures, maintain and perpetuate inequalities. And Sir Marmot suggests that some of these difficulties have been the direct result of government policies. Racism influences which issues are placed on the policy agenda, how they are addressed, and how they are resourced. Therefore, generally, this event recognizes that racism is a determinant of health. Building on that, throughout this event, particularly as the panel presents their case studies, would ask you to keep asking how racism is operating in each of those case studies and commit to considering strategies and actions to address it. We also recognize that racism is trauma, hence why this event has taken a community-engaged, trauma-informed approach. I'll now welcome Dr. Val Ness, who is the head of Department for Nursing and Community and Public Health, to say hello.
Good afternoon, everyone. As Judy says, I'm Val Ness. I'm the head of Department for Nursing, Community and Public Health here at GCU. GCU's Strategy 2030 strives to promote equality, celebrate diversity and embed a university culture focused on belonging. We can do this by being an inclusive place for students to study, attracting a diverse student population and seeking to close those gaps in participation, awards and outcomes for our students, including those from widening access backgrounds. We can also do this, though, by being an inclusive place to work and by engaging with our partners and communities to address health and social inequalities through education and research and events like this today. As the largest department within GCU, with over 140 staff and over 3,000 students studying programmes in nursing, community and public health, including the largest intake of student nurses in Scotland, we're uniquely positioned to also influence the future workforce. That influence extends beyond the classroom and reaches individuals, families and communities, and so having these events on campus where we can engage with our communities is therefore vital. So I'm really looking forward to hearing from our speakers who will be highlighting projects and initiatives that are actively working to redress the injustice of systemic racialised health inequalities, and I'm sure their insights will spark important conversations and inspire action. So thank you all for being here today.
I just wanted to highlight that we have a gorgeous exhibition over in the corner there, if you get a chance to look at it. It's from Sharp and Her, the African Women's Network, and was funded through our Anti-Stigma Arts Fund this year. They also produced a directory for mental wellness, and there's a sample copy there. Please don't remove it, it's our last one. But there's also examples on your table as well. So just an absolutely huge thank you to Judy for requesting our partnership on this event. It's been an absolute joy working with you, as always. And I'll now pass over to our director, Wendy Halliday, to say a little bit about why we're supporting this event.
Good afternoon and welcome. My name is Wendy Halliday and I'm director of See Me. I'm delighted to be here and to join you at what I'm sure is going to be an incredible event. Our job around, or our work around intersectionality and the relationship to mental health stigma has not been an easy one. And we're on a journey here, and there's so much more that we need to do and learn. The existing equality and human rights legal frameworks still address identity groups in silos under protected characteristics, not in an intersectional way. And that means we fail people. Our work supports adherence to and going beyond the public sector equality duty, taking an intersectional approach to understanding and addressing mental health stigma and discrimination. I'd like to end on a quote from Lucian Staden-Forster from the Coalition for Racial Equality and Rights. We know we have so much to do, and without the guiding principles of anti-racism and intersectionality, Scotland's work in tackling mental health stigma and discrimination will continue to fail racialised communities. And that's why we're here today. Thank you.
Thank you, Val and Wendy, for that insightful words from you. What I wanted to do really was, before the speakers come up to the panel, is to remind us why we really are here and go through, and I'm sure you recognize some of these photographs here, and some of these people are actually here in the room. In around, I think that was 1840s, the Tuskegee syphilis study was implemented, and we had 600 men recruited to that without consent. And they were lied to that they were being treated for bad blood. We have then in 1951 there, where we have Henrietta Lacks appearing in a clinic, and her cells, cervical cells were taken and have been used in the treatment of cancer for so many years, but she had no clue that this was being done to her, despite the pharmaceutical companies making millions of money out of her, cancer cells, which are still continuously being used today. We also have the three sisters there, Anaka, Lucy, and Betsy, who are enslaved women and were, forcefully recruited to be the guinea pigs in testing the first gynecological equipment at that time. And somebody else, of course, got the credit for it. And so these are people who are unseen, whose voices have never been heard, but throughout history and today, because we have the internet, we are able to get access to this kind of information, but their voices were completely not heard. Okay, there are many other stories in the media today. We have Sarah Batman. I'm sure many of you would have heard about the exhibition, the woman taken from South Africa to be an exhibit in London, and many other stories. And it was interesting to me to read this week about the Hunterian Museum, having exhumed bodies from South Africa and brought them here, and now they're having to repatriate them back. So there's many stories that we hear about the injustices that Black communities have faced, and basically that's why we celebrate Black History Month. However, these communities have not experienced these challenges passively. We've had many activists trying to address the inequalities, and there's many historical figures and posthumous figures that have been publicized, including Dr. Harold Moody here, who came from Jamaica in the early 1900s and graduated from the King's College London as a doctor. However, he was denied a job, but he ended up setting up his own GP and supporting many Black communities in London at that time. Then today, I just really thought it was important that we also think about people who are continuing to do that activism work today. We have Margaret Lance here, who died about, I think it's 2 years ago, and she worked tirelessly in the communities in Glasgow to address, the challenges the communities experience around HIV. And today we've got Dr. Khadija Cole here with us today, who worked under really difficult circumstances to ensure that, FGM, or female genital mutilation, was put on Scotland's policy agenda. And because of her, many more women have been able to receive potentially, better services than they did before this became a public issue. Then we also have Dr. Harriet Campbell, and Khadija has an MBE and also was awarded a doctorate, a honorary doctorate from Strathclyde University for her work, in tackling inequalities. Today with us as well, we've got Dr. Harriet Campbell, who came to the UK in the 1970s and worked as a nurse until she retired, and has, continued to, work around tackling inequalities in health and in many other areas as well. So I just thought it would be helpful not just to think about the historical figures, but also celebrate those who are with us here today. And also just wanted to highlight that there's been many reports by the Scottish Government, by GCPH, by Public Health about the significant racialized health inequalities. And we cannot name them all, but maternal mortality for me is one of the issues that I find really challenging to, acknowledge that this, Black women face, are 4 times more likely to die in childbirth than, white women. And then we have the issue around mental health as well, how Black people are more likely to be sectioned, receive coercive treatment, and less likely to access talking therapies. And during COVID-19, we saw the, stark inequalities. And what was really interesting for us was to know that despite the challenges we were facing in the diaspora, communities on the continent did not experience the same level of harm from COVID-19. And then there are diagnosis delays, and we hear every day reports about staff experiences in the NHS and with barriers to progression, discrimination, and being scapegoated and so on. And so the conversation today is really, really important. And that's why I'm delighted and really grateful that we have, some case studies to present, because whenever all these things have happened, communities have not sat back. There's people from these communities who've come out to challenge, the inequalities that exist. And so today we have 3 case studies from the community. We have Lekan, who's going to be speaking to us about sickle cell. Lekan, you can just come up. And then we have Dr. Josephine Adekola, whose work around vaccine mistrust has been quite instrumental in learning for policymakers and researchers as well. And then we also have Dr. Krithi Ravi, who's a doctor with the NHS, an anesthetic doctor, and she'll be speaking to us about pain and anesthesia. And then we also have Sahej, Rachel Gray from CIMI, who are going to be speaking to us about mental health, stigma, and discrimination.
Thank you, Judy, for that, for such a good start, and thank you to Judy, to CIMI, to GCU, and the team. And very good introduction. The first step of solving a problem is to know. Solving a problem is to name the problem. So it's good that you set the scene by doing that. Now I'm going to prepare you the panel. We're talking about lions telling their story, so I'm going to ask you to prepare a 1-minute introduction of yourselves. I'm going to say a bit about you, but I'm preparing you now that is what you're going to do. So you have 30 seconds to prepare your 1 minute about yourselves, because I don't want to speak for you. But before you do that, I'll introduce myself so you've had time. No, I've been thinking about it. So I'm Fiona Matovo. I'm co-founder and director of Radiant and Brighter Community Interest Company. I do all the work. My husband is sitting behind there, and he sits while I do the work. And today I'll be chairing the panel, and I hope we go away with quite a bit. Something that I was thinking about as you were talking here at the front was the importance of us talking about the challenges, but also acknowledging, as you said, Judy, that the communities have not been sitting back. And that's really important, so thank you.
My name is Olalekan Oyedepo, and I prefer to be called Lekan for short. I'm a co-founder of the Hope Project Scotland, and also one of the only 3 permanent volunteer staff on it. We've been operating for 9 years now, and we support people with sickle cell anemia and thalassemia and their families. Sickle cell is an illness that affects people from usually African backgrounds, Caribbean, Southeast Asia, places where you've got like malaria and mosquitoes.
Thanks so much for the invitation, Judy. Really appreciate it. So I'm Josephine Adekola, a senior lecturer at Glasgow University, or if you like, an associate prof in management at the Adam Smith Business School. Aside my academic career, I'm a mom of 3 boys and a wife as well. So to introduce myself, just like every lecturer, we teach, we do research, but I'm quite big on the research side. And I've been researching into communities here in Scotland, especially around vaccines uptake and factors that either influence people to take the vaccines or not. And looking at the multidimensionality of the issues, and I'm hoping that the conversation today will allow me to touch on some of the findings from my study. I'm also the head of Atenas 1 of the business school in Glasgow. I'm also a global health and environment interdisciplinary research team lead. So I'm one of the 3. So we gather people to talk about issues around health, global health, community health, and environment. And as part of that role, what we do is organize events just like this one. So that's me for now. Thank you so much.
I'm Krithi. I'm a resident doctor in anaesthetic and intensive care, working in and around the Glasgow hospitals. But more importantly, I'm a daughter, I'm a sister, I'm a friend, I'm a carer, I'm a patient. So that is where my true expertise and legitimacy sort of lies. It's not the kind of stuff you put on LinkedIn. I look at anti-racism in the NHS as a patient safety emergency. This is not EDI, this is not wokeness, it's a patient safety emergency. And a lot of my teachers are in this room. The soon-to-be Dr. Matovu, Dr. Wasige, Professor Jackson, Laken. So yeah, I'm really honoured to be here alongside them.
Hi, my name's Rachel Gray. I work at CME on mental health stigma and discrimination, and with a specific focus on health and social care settings. So I bring over 20 years of working at the grassroots of intersectional feminist practice, and I specialise in supporting the development of radical political literacy in communities, institutions and organisations. Thanks.
Thanks, Rachel. Hello everybody, and it is a pleasure to be here amongst all of you. My name is Sahaj Kamra, and I am one of the project officers at CME, Communities and Priority Groups. Woohoo! I'm also a founder of a non-profit back in India, my hometown, Hanumangarh, which aims to tackle educational inequality back there. I've been working at CME for about 2.5 years now, and my work has mainly focused on working with grassroots community, collating evidence, and which is crucial in organization taking an intersectional approach, and my pronouns are she and her.
The question I want to ask is, the NHS is internationally recognized as a comprehensive universal healthcare system across the world, providing care in the UK, and it's needs-based rather than ability to pay. Why might specific healthcare conditions need to be dedicated in way of projects or charities, even within the universal healthcare system like the NHS?
So, the NHS is a fantastic, institution in Britain. But sometimes it's good to rewind to understand what the issue is now. We need to go back. So the NHS was framed by William Beveridge as an institution that might guarantee the legacy of British ancestors such as slave trader Francis Drake and ensure the health of the best of our breed. It was pretty much eugenicist and racist from the conception. And so if you're trying to tackle the inequalities now, you have to understand what's woven into the foundation of the institution, right? In 1968, the Commonwealth migrant labour made up 30% of nurse people vacancies, 29% midwives. By 1975, it was 18% of GPs and 32% working in essential services were born outside of Britain. But this also happened to be the lowest paid roles, even though they were essential to the service. Since establishment, Black and Asian people have been excluded from the notion of entitlement because NHS is part of the welfare state, right? And so the system was not set up to prioritize care for Black patients, but it was staffed by Black nurses who experienced and witnessed racism directed at themselves and other Black patients. So I've got sickle cell disease, which primarily affects people that have got African heritage. And so I have to deal with that, I have to navigate that. And you have to understand how much resistance there is in. I told Judy that I was going to start today with an anecdote. It's 2025. I have to see a lot of specialist, carers at the NHS. And I was at one just this last week. And before I could sit down, the doctor said to me, wait, I'm going to guess where you're really from. I didn't sit down. And it was like, Nigeria. I'm like, yeah. Because I have a colleague in Nigeria. You look just like him, except you've got hair. And so there is a cultural shift that's required, right? It has to go beyond just the education, because we do that. We educate the NHS at the whole project. Like, we're on the SPA network. And so we talk to them regularly, and I think there needs to be an acknowledgement from the NHS about its founding principles and where it really wants to be before you can actually then provide the care.
So like I was saying, the NHS, is a big system, right? And it deals with a lot of issues. And I want to believe that they prioritize on issues that affect the majority of the population. And that kind of calls for the need for those other kind of project-focused initiatives to allow us to be able to focus on specific groups as well. Because if we don't have that, we'll have a case of inequalities or aspects within the health system that is not, giving the desired attention.
Obviously, CME are looking at the healthcare system, specifically paying attention to mental health, stigma and discrimination. And so the idea of what is a universal health system has come up in our work. So we have decided to take an intersectional approach to stigma and discrimination because this rejects the idea of the universal. We know that mental health stigma and discrimination has been historically analysed and addressed from a universal perspective, and we've been recently and sadly hearing the term a general population approach. And I think that nobody in the room is silly enough to not know who that means. The Gen Pop approach inevitably assumes and serves a default human being, which we know is white, cis, male, straight, non-disabled and middle class. And because of this, it essentially fails to attend to represent, to recognise and to serve everyone else who is not that default universal human being. And I'll just very briefly talk about some of our successes in terms of taking an intersectional approach to mental health, stigma and discrimination. So basically this approach has helped us to attend to where a Gen Pop approach fails, to the complexities of intersectional lived experiences across race, ethnicity, disability, gender, sexuality and class and beyond. And further, it allows us to recognise and address the historical and contemporary systems of power and supremacy and embedded structural discrimination that minorises intentionally communities of people. So, an intersectional approach has allowed us to address mental health stigma and discrimination in a way that recognises the realities of people's existence than the realities of people's lived experience. And at the same time, intersectionality provides us with the tools to dismantle systems of power and structural discrimination and inequity in mental health services and related institutions, because we know that our social institutions are also all intersectionally linked. Housing, education, the welfare state, health, everything is linked. Yeah, that's me.
Thank you, Victor. Which is really important and which recognises people's realities. Jasad, what successes are you seeing?
I think Wendy has shared most of why we have taken an intersectional approach, and Rachel has shared as well. What I would like to say is that if we need to tackle mental health stigma and discrimination, as we say, for everybody, intersectional approach is a must. The universal approach is not going to cut it for everybody. And CME's focus on intersectional stigma and discrimination has really been about understanding how racism, sexism, all these isms affect people's experiences. And then it has been about shifting the perspective of stigma, seeing stigma as just an individual issue that operates at an interpersonal level, but it is embedded insidiously in systems, in structures, and in institutions that we are very much a part of. So it's about rethinking that again. And as the most important thing that I really like about intersectionality is about critical thinking. Like for CME, as when I started working, I began researching what stigma and discrimination is, basic thinking about definitions, how we communicate, to the partnerships that we started building, to even the Anti-Stigma Arts Fund that we fund and the organization that it has reached. So it's about reaching the most marginalized populations. I'm also the other thing that I really like about is understanding how historical underpinnings reproduce stigma, and that reframing has been very, very crucial for us in the organization as well, because we began digging what happened in the past, because that's the legacy that we are living today, and that has been a really big success for us at CME as well.
Why is advocacy really important, particularly in anesthesia, pain management, for racially minoritized communities here in Scotland?
This advocacy work is embedded into every part of justice, but have folk here had interactions with anaesthetic doctors or intensive care doctors? Yeah. Often I think we tend to see the anaesthetic and intensive care doctors tend to see themselves like maybe not frontline clinicians. We get referred to patients by other specialties, so there'll be like a surgical doctor that says, oh, this patient needs to have this surgery. There tends to be inbuilt distance in a way to distance yourself from the patient and their wider needs. But I think it's very well recognised that equity in pain relief is one of the major structural health problems that we're facing in the NHS at the moment. And pain is our bag, that's what we do. So tell this room about the inequities in COVID-19 mortality, and so many of those deaths happened in intensive care. So I was working in intensive care with doctors that looked nothing like me, integrating people that looked like my parents, calling their relatives and say, do you want to say goodbye to them? Because they're going to go off to sleep now on the phone. So it's, I think that distance is a function of privilege because of the fact that you can distance yourself from the pain of the communities. The reason it's important is that pain relief is a patient safety issue. Equity in pain relief is a patient safety issue. Equity in intensive care outcomes and anaesthetic outcomes is a patient safety issue. But also, as anaesthetists and intensive care doctors, we interact with a wide range of hospital specialties. I think anaesthetics is actually the biggest hospital specialty in the NHS. Basically, if we have data on race ethnicity that we can link to outcomes, there is demonstrable racial inequity. So, unless proven otherwise, given, as Lakin has demonstrated, Dr. Wasige talked about, given the supremacist whiteness-centric values that informed the building and continuously to inform the ongoing funding and strategic prioritizations within the NHS, unless proven otherwise, we must assume there is racial inequity in racial outcomes. There is excellent decades worth of evidence for this. Public sector equality duty to monitor the inequity in outcomes by intersectional characteristics, including race, ethnicity, disability, minoritized gender status, minoritized sexuality. It is their public sector equality duty. This is not for broken up, unfunded PhDs. Okay? We need to embed this data infrastructure within the NHS. The fact that we have not done it despite decades worth of evidence and despite the patient-saving catastrophe that was COVID-19 pandemic is honestly.
Thank you, Dr. Brickney. And you mentioned the public sector equality duty. What is interesting about that is that, maybe not interesting, but when the public sector equality duty came into effect, it was directly into the result was a matter of Stephen Lawrence. And so at that point, following the reports, which I referred to mention, Stephen Lawrence was a gift to us from his mother and not the reports he wrote, which I recognize is important in the right report. But that is where the public sector equality duty comes from. When we talk about it now within the public sector, and it is synthesized and somehow has been cleaned out of any racialization. And so we talk about it like it doesn't have anything to do with that. So really thank you for reminding us of that. My question to you is, why is it important that we address racism and inequity not with the standard EDI models that we have? Why do we need to take a different approach other than the standard dominant EDI models?
Yeah, but I think as the head of Atena Swan at the Adam Smith Business School, one of the things I would say about EDI is that it addresses a whole range of issues to the point that it becomes impossible to focus on any specific issue to give it the level of attention and details that it requires. So, and that's the reason why we need a more, like she did say, a more intersectional approach. Although, some of the comments people make would be that, we need more initiatives that unite us rather than divide us. There are debates around that, even if that itself could be a problem, because when we only focus on things that unite us, it means that people who have extreme situations, they're going to be left out of the problem and experiences. So it's important that we take a different approach, especially when we have to deal with issues around racism. It's quite a unique experience. And to be fair, right, Scotland was built for a long time ago. Scotland didn't just exist. Immigration, is to Scotland has evolved over time, but more recently within the last 20 to 30 years. So we would expect that the system would evolve as well, but originally not built maybe with us in mind. but over time would expect that we take that anti-racism approach to address issues that relate specifically to racism, because it does have implication on life experiences and health. We could take the broad EDI approach, but like I did say, EDI does cover so much, a broad range of issues. We hardly address issues around racism, because there are issues around inclusion. You're talking about gender balance, you're talking about governance, not necessarily racism. It doesn't mean that, those conversations don't come up, but it rarely does. So we really need a different anti-racist approach that allows us to focus on this important conversation that impacts on the lives of certain communities, and in this case, racialized and minoritized community. And we are disadvantaged on multiple levels. And, and we need a more sympathetic approach to how we deal with this racism. And from when kids are born up until, it doesn't have to be something that happens only in healthcare, but rather from their life experiences, the opportunities that are available to them in primary schools, in secondary schools, all through to universities and all that.
So with the approach that you have taken, which I know to be the anti-racist, decolonial approach, right? What successes are you seeing, and where is the place for COPE projects and any other projects that I'm seeing?
So successes with anti-racist approach for us is that because racism is such a pervasive and storied institution, we end up internalizing it sometimes. And so because at the root of what we do is anti-racist, we end up helping our community members to shed those harmful learnings. So that's the first benefit for us, is that our community members begin to gain an awareness of their own internalized racism. And so it reduces the harm that they do to themselves and that they do to other people in our community, and also the way they end up living their lives. Because racism has, a determinant on your life. And so the amount with sickle cell, there's so much pain there, and we plan, or we aim to reduce that. And so reducing the amount of harm that people come in contact with is a priority for us. And so that's where that comes in for us. And in the wider approach is also, we do a lot of advocacy work and a lot of awareness raising work. And so when you're in our space and you're engaging with that approach, even if you're not of the community, you can then learn, and then that protects our community, because then you are inflicting less harm on them, right? And also you're inflicting less harm on other people. But also being anti-racist actually helps you on an individual level, if we're not talking about systems, right? So racism brings with it hatred. It also brings with it making poor choices that will negatively affect you, because you are operating via the lens of prejudice. So when you think this person is a danger to you because of where they're from, you are not focused on the actual dangers to you, who are the 1%. And so if you then are in solidarity with your fellow community members, you are less likely to make choices politically and otherwise that will actually negatively impact you. And so that's another benefit that we found of the anti-racist practice that we do. And so for the whole project, what we are focused on is not just the clinical outcomes for our community members, it's also the outcomes everywhere else. Because most of our community members are either Asian, African, or adversely racialized people, health is important in the sense that it affects everything else. And so most of our community members either are single mothers or single parents. And so if we can help them tackle or take care of the health element, they have more resources to dedicate to other areas of their lives. And so they will receive help in other places that will improve their outcomes elsewhere, like the financial outcome and the housing outcome and all those other things that make life enjoyable.
Taking an anti-racism approach is actually very therapeutic for a lot of people. Because when I go to communities and we have conversation, one of the things they come to thank me for is that, thank you so much. I thought I was running mad. I thought I was, having these things built in my head. I thought the problem was me. So you hear people tell you that, and thank you. Hearing the experiences from other people can really help the communities themselves who are being traumatized by these, experiences. Because most people kind of internalize it, or they hide it. They feel it's shameful to be, you've been discriminated upon, but you're ashamed to say it out. So a lot of people just hide these things and just endure the pain and the trauma that it brings. But taking this anti-racism approach and creating that space for this conversation to happen is really, really therapeutic. And I would say this is one of the strongest benefits of the approach.
I just wanted to pick up on something you said there about like people coming up to thank you. And I just want to highlight there that the vast majority, I think every single theorization, every single sort of type of theorization that I've read around explaining racial inequity in health outcomes has been damage-centered. Actually, in all of the major health journals. And what I mean by that is that situates the deficit in the individuals or the communities. And we see how this impacted policy in COVID-19, okay? Because when I went into hospitals, the doctors around me would say, oh, just take your vitamin D. I've never seen a single vitamin so maligned, because the problem with vitamin D is that it's linked to melanin. Do you know what else is linked to melanin? Racism. So this damage-centered theorization has really, really, really held us back. And I think that is actually a really big block to looking at anti-racism as a communal liberation practice. Because if you think of anti-racism as fixing deficit in a particular community, there's no way in which we are all going to be collectively liberated by it. The deficit lies in the system, okay? And on that topic of the Gen Pop approach that you were talking about, that's really captured my imagination. I invite you to think about the political economy of why the Gen Pop approach is emphasized in public health, while pharma companies, the way that they're making money is through targeted therapies. They are making money by having therapies, drug treatments that target very specific gene mutation, very specific proteins. The more specific, the better. All of the IPOs that are being floated in the stock markets with regards to pharmacy startups focus on this personalized targeted therapy. Okay, so what's the political economy of that? Why are we able to target molecules and not look at things that actually, it's not even targeted because anti-racism, I can't think of a single service, like health service, that I would consider to be unsafe for adversely racialized people that I would say actually white people are safe. Do you know what? Gives amazing outcomes for white people, but just unsafe for adversely racialized people. No, it's not that way. What we see is inequity throughout. It's just magnified by the intersectionality of the challenges that we face, which I'm sure you see in mental health.
Just as you were saying it, I think it's a wider misconception that there is stigma within the communities, in context of mental health. So there's a phrase that I always remember. A community member said to me that we are not hard to reach, we are hardly reached. We are just not reached, we are not heard. So I totally agree with everybody that has said that on the panel. And it's not I think Judy had mentioned it when she was presenting, that there's strength within the communities, and we need to focus not on the deficits the culture deficits, that's the phrase that we hear all the time, stigma within communities and deficits. But I think there's a lot of strength and we need to utilize that. I think we need to come together and thank you.
So my question to you, Rachel, to everybody is, why is it important, as Dr. Quigley said, for us to focus anti-racism on the structures, on the systems? Why is it important that we don't individualize it? Even with its liberatory nature, when we have those conversations, Why is it important that you focus it on the system? So your approach, the intersection approach that you've taken, looks, I imagine, at the systems, the processes. Why is that actually important? Because a lot of times when you talk about racism, it becomes individual. When you talk about the work getting done, it becomes the deficit model, we're the deficient ones. So they'll fix the people of color, they'll fix, the system never gets fixed. Why is it important that we target the systems, the processes, the structures that we have?
So at CME, we are pulling from the work of Dr. Carla Perez, who has been developing the SCIP model, which is a socio-economic model of understanding discrimination and stigma. And so that is literally that we look at the structural, the cultural, the institutional and the personal. And Kriti, you spoke there about the personal level, the internalised racism, the self-blame, and what we see within intersectional mental health stigma and discrimination is huge impacts on self-esteem, sense of worth, all of those things. We have to look at the other levels, because at that point we can start to identify exactly where the dismantling needs to happen and where the solution finding needs to happen. So at the structural level, we know that there are certain legislations that cause poor mental health outcomes directly for specific communities of people. There is racist legislation, there is homophobic legislation, misogynist legislation, and all of that legislation has an impact then down at the personal level of the SCIP. What we also see is there a link between the legislation and also the ideologies that come out of governments that then also have an impact at the personal level, but they're also hitting at every other level. They're hitting at, and they're also intersectional too, so they're all feeding off of each other. Who is causing racism? Are they causing, is it the media making racist statements, or is it the government promoting racist identity? It's a machine that feeds itself, and I want to say, and they're all in cahoots together because they are, and that's the reality.
Yeah, and just to kind of build on what she said, I think it's important to focus on the broad systematic level for two reasons for me. Because one of them is sending a strong message from the top. You hearing about the prime minister, the first minister talking about these things is really important. It sends a strong message to everybody. But more importantly, it helps to tilt the landscape. Because how racism works is that it creates a landscape this way, where some people are at the top and some people are at the bottom, and we are all working to the same level. But if we can take the systematic approach, it's kind of tilting the whole landscape, and it helps.
90 degrees.
Yeah, and it helps everybody. But the problem with focusing only on the system approach, is that it takes time, and it may never come. So, yes, yes, no, it really does take time. We're still talking about ethnicity data collection till today, since COVID-19. We still haven't finished it.
Still understanding.
Yeah, we're still trying to build a system despite meetings and meetings and meetings. It's like we never get there. And if we ignore the other levels, then we're going to be in trouble. So we need to really do all of this simultaneously, hoping that in the long term, the system will really change and change the landscape for every single person.
Yeah, so I do agree with a systemic change that is needed. I think what we need to ask each other is, at what level do you see the change happening? what's your limit to the amount of action that you will take in service of anti-racism? So we are in a white supremacist, political culture. And so there is advantage in the political class to wield racism, even regardless of the benefit it had in the past. And so if we're going to tackle it now, there needs to be a cost to racism. And so as far as the political class knows, there is only benefit to be had from it. And so what is the challenge to everybody here is, where is your line? Like, are you about just going to meetings and talking and writing petitions? Are you about protesting? Are you about demanding a change to the white supremacist culture in which we all sort of living? So if you want to dismantle racism in the NHS, it's not going to last, right? Because NHS is not an isolated institution. It works with every other institution in Britain. And so if you want to dismantle racism there, you need to dismantle racism in the political class, because if they have no benefit to pursuing racist legislation and racist rhetoric, and so when that is gone, who else is like, what's the advantage in anti-racism for the political class? There is none. And so we are not going to defeat it by defeating one institution, because if you defeat it in the NHS, it will just come back. It might take time to come back, but it will, because the rest of the environment is still racist.
Yes, right. Yeah, say it again for the people at the back. I just wanted to maybe just point out also that one of the reasons why I think there continues to be like low cost to racism is because all of the trauma, all of the grief is borne by minoritized people, right? Okay, so there's something here about, and I absolutely, please do not apologize, because this is traumatic work, like this is, fam, like I'm like raging. This work is like, but the fact that we feel like the legitimate change-making spaces are behind institutional walls, and that we have to sanitize our experiences, take the grief and the tears and the rage out of them to bring them into somewhere like this. Like, that is one of the very important ways in which the cost of racism is mitigated. It is deliberate.
Yeah.
It's so deliberate to force us to repress our rage. Because I've got to be professional, don't want to be GMC'd, don't want to be proscribed.
The cost of racism being borne by the adversely minoritized groups. And I think that is 90% correct, because the 10% of the trauma, of the challenges that the mainstream white people face, the repercussions of their racism is subsidized by the state. So when Brexit came along and people voted against their interest, but then they have access to loans, they have access to services. So even though it sucked for everybody, it sucked for them too. But then if I walk into a bank for a loan and another person goes into a bank, there's a difference in the amount of care the state has for when we're both down. And so the cost, there might be some cost, but then it's subsidized, and it's mitigated. And so you can go, that really sucked, I shouldn't have done that. But there is a little bit of help, that you can access, that I may not be able to access.
We all agree, it's traumatizing, it's exhausting, but you do it anyway. So, there are people here, we started off by acknowledging the work that's been done by those that have gone before us, the shoulders on which we stand, anti-Harriet. You mentioned the skip analysis that Dr. Carlin, I work with her, she speaks about it all the time. And then, seeing the work that's getting done by, we are building on that work. And we know, as you said, that when we are doing that work, at some point, the system recalibrates.
Absolutely.
And so maintaining that momentum and keeping it on the radar is challenging. But we have people here that are involved in different areas. So my question to you is, what is your message to those of us that are here, perhaps have the opportunity, there are people here who have, so the actual question is, what would you give us in here today as homework? Not because it is on us, but because it's incumbent on us to educate, challenge, create the pathways for the system to change. Okay? So, what would you say to those of us that are here? One of the things that I learned is that we talk about power as if it's not within us. We have power, regardless of who you are. So, what would you like us to go away with?
Okay, I think my exercise for us is to think about a post-racism world. In the sense that, we're here to discuss anti-racism. And so that is maybe a lot of time that we're investing in this. What could we be doing instead? What else could we be sat here doing if we were not here to discuss the end of racism? What are the advances that we could be making? What are the good times we could be having? What are the actual progresses that we could, be engaged with? And to that effect, I want to rewind back to when I asked, where is your line?
I speak a lot to scientists, especially those who produce the vaccine itself. And one of the messages I often give them, which I'm sure would benefit others here, is that you need to be aware that science alone is not the issue at stake. So whatever health information you have, the health data, the evidence, or whatever you have to offer to communities, you need to be aware that that issue or that thing is not the only issue at stake. That there are other issues that really shape how people perceive or receive what you're offering, whether it's an advice, whether it's offering a health product or initiative. There are historical issues, like Judy kind of explained in her presentation. There are historical issues that has happened in the past that are influencing whether people receive that information you're giving them or not. So you need to acknowledge those historical injustices in whatever we're trying to offer to people. Also, we need to be aware that when we talk about trust, because when we are communicating with people, with communities, with patients, trust is really important. But we should be aware that trust is based on the wider societal treatment of people. So it's not, I don't build trust in the NHS based on how a doctor treats me or somebody on the phone speaks to me, but rather how my experiences, how the immigration system treats me, how the education system treats me, how I'm treated in housing sector or on the bus. So we need to think about trust from a wider perspective. That whatever we're doing, no matter how little, no matter how we treat people, ourselves in the workplace, all those does have implications for trust. And that should help us to reflect in how we relate and treat each other. And finally, is that everyday experiences of racism, microaggression, and discrimination does affect people's willingness to accept whatever message, no matter how good you think it is. If you think about the case of COVID, one of the communities that were dying most from the virus, from the NHS data that came out first, were the Black communities. But they were the one refusing to take the vaccine when the vaccine came. And I was wondering, how could it be? How could this be? You're the one dying, you're the one refusing. Again, and it points to the fact that we need to really acknowledge people, these historical injustices, people's pain in engaging and in communicating with them. So, and finally, we need to address racism. And I think the anti-racism policy that is being pursued in Scotland is a good initiative. And we hope that we can really see it come to full manifestation.
My message would be that representation is not liberation. And I would strongly advocate for anti-racism advocates within institutions to function as co-conspirators with community advocates. Okay, so we need to go with humility, with the explicit intent of learning from communities about the causal pathways
which lead to racial inequity. Because there are very many causal pathways. We haven't got time to go into them. There are causal pathways. Lakin can tell you about the causal pathways in sickle cell. Josephine can tell you about causal pathways in vaccine inequity. You can talk to us about causal pathways in mental health. Right? There are actual pathways which are actually targetable. So use that to design and validate your data infrastructure and put anti-racism work in your institutional annual budgets. If it's not in the budget, it's not a priority.
So I've been thinking a lot recently about backlash and really revisiting anti-racist backlash, writing on that, academic writing from the 1960s, 70s. And it's because I am tired. And, the system will always keep us working. It will always keep us dismantling. And that work is so exhausting. The constant goal shifting, the tactic changing, and then we map the tactic, and then we devise something to eradicate that tactic, and then there's a new tactic, and then we do the same to that over and over and over again. But what I really pull from backlash theorising is the importance of exactly what Lekin was saying. Imagine utopias. Imagine what the world looks like when it's not this. And also that body of work, that historical body of work, really teaches us how not to get into the play of unpicking the tactic over and over and over again, and it teaches us how to survive. So I would say look at backlash histories, especially anti-racist ones, because they are life-giving, energy-giving, and they teach us how to survive this and how to imagine utopias.
Thank you everybody for that profound message. I'm going to take all of that away with myself today as well. I think for me, I'm an optimist, so I'm going to give a hopeful answer. It's about, I think, for me, acknowledging the past injustices, very important, looking at where we are, why we got here, and then looking at what we can do today and reimagining the futures, or what can be done and what needs to change, and coming together. I think there's a lot of strength in solidarity. The system changes need solidarity, so we need to come together and make the change. And I think the reason we are here today is because we want to make a change. So thank you.
Thank you, Sarah. Thank you. Really appreciate your time, your honesty, the conversations that we are having here today. One of the things we've all alluded to is that the very function of the system is to keep us busy.
Yes.
Busy working on, one of the things that happens within these systems is that even when we talk about anti-racism, or we talk about decolonization, or concepts like that, then we get stuck on the definition. But we don't have a definition. Mm-hmm. We're not trying to solve the definition. Mm-hmm. We're trying to solve the challenge. So we really need to be thinking about, like you said, what could we be doing? I could be in the Seychelles.
Do you understand? We could be having a dance.
We are doing something. Right? So really, as we finish with the panel, let's take these conversations to our spaces. Let's have the conversations. Let's not stop, but absolutely let us not stop at the conversations. There is a proverb that says, and I used it yesterday in a different setting, and it says that a chattering bird does not build a nest. So we cannot just be, we have to take some action. So go away, do something. And to finish our discussion here today, if you're thinking, but I can't really do anything. If you think you cannot do anything, you think you're too small to make a difference, then you haven't spent a night with a mosquito. So really go away and do something. And thank you to our panel, thank you to Judy, thank you to everyone who's organized. and you have earned yourselves a break. We have a break now, and we'll come back within 10 minutes at 3:50 exactly. We start that. Thank you very much.
Vana vanochema mdzimudzoka, kwaziwe changamire mdzimudzoka. Vana vanochema mdzimudzoka, kwaziwe changamire mdzimudzoka. Vana vanochema mdzimudzoka, kwaziwe changamire mdzimudzoka. Vana vanorwara mdzimudzoka, kwaziwe changamire mdzimudzoka. Lekani. 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 Like street dreams grown by insatiable needs, these autumn leaves blown by inevitable winds create a colorful gathering here in this place. A kind woman met me as I arrived. A warm smile and colorful presence matching the autumn leaves. Inside, there are tables, pens, and curious, colorful toys. Matching the autumn leaves, hanging display and offering, suggest in colorful image, sharpen her, see me, open eye, butterflies and leaves in cyanotype, urging elegant flight from stereotype, saying, we are strong. Go girl, and these powerful, powerful words. I forgive you. I forgive you. Inside, music broth of voices, greetings of reconnection. Instead of what do you do, how do you do? Inside, music broth of voices. The system doesn't care enough. Sharp edges everywhere, cutting conversations short. A kind woman meets us all. She invites us to focus on lifting the conversation, shifting our observation. She begins with naming, in the same way we began with naming, writing our names on stickers. She begins with naming. Racism, a determinant of health. In this gathering, as far as possible, be informal. The engagement should be trauma-informed. And we have someone here who is trauma-informed to guide us, to hold us. And so to the topic, when lions roar, why does it sound like silence? Out there. When lions roar, why does it sound like silence? In here. How do we get to this widening access in the midst of narrowing minds? How do we get to this living in equity when history has given us the mathematics of inequality? Are those in policy noticing this unjust reality experienced by way too many people? So to stick to the topic, when lions roar, why does it sound like silence out there? When lions roar, why does it sound like silence in here? For these autumn leaves, broken pieces, unable to fit, though they keep trying to blossom. Dehumanized bodies, exploited and abused for education. for knowledge in the history-old industry, reproducing stigma, general population approach, general population approach, gen pop 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 approach in the history-old industry, reproducing stigma. Yet the lion roars. I am a daughter, sibling, sister, patient. That is my real expertise. You have to understand how much resistance there is. So it can only be done by going beyond education. The lion roars to dismantle the systems of power. No one is silly enough not to know. The challenge to everyone here is, where is your line? Where is your line? What is universal? Like falling rain. Mvura kunaya, haina pa inosia. No less, we need to do more. We have to do more. The chattering bird does not build a nest. We have to do more. Vana vano wana mzimzuka, kwaziwa ichangamire mzimzuka. Vana vano chema mzimzuka, kwaziwa ichangamire mzimzuka. Vana vano chema mzimzuka, kwaziwa ichangamire mzimzuka. Vana vano rwara mzimzuka, tovera oye mzimzuka. Vana vano rwara mzimzuka, kwaziwa ichangamire. Yes, thank you. I just want to start by acknowledging the organizers for this, because when we come together, when we say the gathering is sacred, that is not a figure of speech. It is sacred in the literal form, in the metaphorical form, because when we live here, no one is the same. We're all completely transformed. We have stories inside us that we're going to go and share with other people. We're going to go and spread them all around. So a gathering is something that I really appreciate. And my job today has been my favorite practice, which is of listening. Listening, something that is so difficult to do. And we don't think about it that often, but I'm grateful for people who remind us to think about listening more carefully. Just like there's a journalist called Celeste Headley, and she was talking recently about the habit that we've developed of listening to respond rather than listening to understand. So I want to just put listening into the mix so that we can think about how we practice that better. So in that practice of listening, I am just listening and sharing back the words that I'm hearing in the room, and of course adding some of what my own reflections come with that. And I'm hearing in the room the idea of, can we talk? Can we talk? Can we talk to each other? Can we talk to people? Just now, it is very difficult. We were having a conversation earlier about how difficult it is to have conversation with people because there's so much misinformation and the power of stories. I'm a storyteller, but stories are not a positive thing, always, because it's the same power of stories that is being used to spread misinformation. So how can we talk? Can we talk to people who hear someone on the phone in a different accent or language on the train, and they get angry and they lift their bags and they go and sit in another seat? Can we talk to those people? Can we talk to our neighbors who see us coming up the stairs and they pretend they've forgotten something in their house and they rush back up? Like a horror movie, and they're trying to open the door so quickly before we arrive. Can we talk? Can we talk? Being aware of our different languages that we use in our own disciplines. We have specialist language. can we talk in a way that we all hear each other? And this idea of the problems we're talking about are continuous through society. I'm hearing that in the room, that these things don't just stop in one moment. Everywhere you go, you're always contemplating. Something might just happen to remind you again. So there's this continuous. And that continuous thread is also historical, because history has brought us here. We're in the aftermath of what has happened through empire mainly. I like the idea of rights and duties, because the work of decolonizing is for everyone. It's the same as the work for integration is for everyone. It is everyone's responsibility. We have to think about what our roles are. There's an elder called Mandaza who said that colonization is a wound that affects everyone from different angles. And so we position ourselves where we think we can do the work with that. I like the word to tackle, because to tackle suggests we have to be agile. We have to be strong. So what is our training in order for us? There was an important line that was given of challenging us to say, what is your line? What is the work? What do we need? So what is it that we need to do? Because as much as I can want to be in the 100-meter sprint final, I can turn up there and all those guys will be finished having their lunch before I even get to the line, because they train every day. Do you know the 100 meters? People train for 2-3 years to run for 9 seconds. You know? So there's something about practice and training. Training is the reason why a paramedic will rush to a scene and start assessing the situation in a rational, calm way, where most of us might probably just start running away. They don't do that by accident, it's by training. What is it in our daily practice and daily living that is going to allow us to really attend to these issues? I love the word confidence that came up in the room. Confidence. Where is confidence? What takes confidence away? What builds it? What harms it? What lessens it? What brightens it up? We have to really think about all these things. We have to see ourselves in the system. One of my friends, I called him, and we're in the car, my wife is driving, I'm sitting, and he said, "Oh, where are you just now?" I said, "I am in traffic." And he said, "No, you're not in traffic. You are traffic." We have to involve ourselves in this. We are in it right now. So I love the word acknowledge. I think it came from this table. So acknowledge, I really love this word because acknowledge is a verb. I am noticing that in the 16 languages in Zimbabwe, we use more verbs than nouns. And I want to encourage you to think about verbs, because verbs are words of action. Nouns are concrete things that are usually quite rigid and difficult to move. You could maybe just turn them over or roll them. But I feel like verbs, there's something about verbs. And in social sciences, Tim Ingold writes about that. That he says actually he's suspicious of nouns because of this suggestion of ownership. And we tend to own things when we use nouns. And so after saying all of that, I want to say I am very disappointed in all of you here. And I'm not joking.
Why?
Why, you say? No. I'm playing obviously. But I want to encourage us next time to utilize the well of resources that we have in our bodies here. We have missed out. Thank you, Fiona, for sharing the Proverbs. But guys, the languages we bring are rich with different aspects of looking at things, of thinking about things, of formulating questions, of conceptualizing things. I just want to bring that into the room. We are using English as the lingua franca, it's fine. But I want to hear someone say, in our language we use this word for this thing because A, B, C, D. That is very exciting to me because you find yourself going, in so many different exciting directions. And I'm speaking from experience. In research, when you sit with a group of researchers, recently sat with a group of researchers talking about migration, and we thought we were talking about the same thing for months. But one day I just said to everybody, can you just say a little bit about migration in your own language and tradition? It's amazing what came up, because up to that point we were talking about migration in the militaristic border control kind of narrative. But when you talk about migration, different cultures start telling you, well, it's a rite of passage. People have to move. The kind people of Ghana are starting to tell you that the bird that doesn't fly doesn't eat. When you have those kind of philosophies embedded in your life, you're going to think very differently about ideas. So I will not leave without telling you a story. I'm going to condense it very much as I can because time. But I think it's a gift I should share with you. Stories are very powerful for me because they helped me when we were younger, my siblings and I, growing up in Narare, and we were going to these posh schools, and the teachers sort of made knowledge look like something very complicated, wearing their gowns and all of that. So you can imagine the gaze we had for our grandparents, who were living their sort of rudimentary looking life. But storytelling, there's a magic there that a lot of it is still returning to me at this time. So just how knowledge is made, archived even, and transmitted, all of those things are very fascinating to me now. So I'm going to share a story that can help us reflect on the situation we're in. Nzo and Tsuro were neighbors. Nzo is the elephant, and Tsuro is the hare. And the two neighbors lived side by side. One was lazy. Who do you think was lazy? Yeah. Funny enough, it was the elephant who was lazy. So Nzo is lazy, doesn't farm, but Nzo was lazy for a reason. Nzo was big and strong, and hare needed protection from time to time. So Nzo said, for the protection, you feed me. So the year of drought comes. Scotland doesn't know what that is. And Nzo, not farming, and Tsuro grew these 3 big pumpkins. And they were growing nicely. And one day, Nzo came over and said to Tsuro, I'm really starving. Can I have something to eat? And Tsuro said, no, I'm still growing my pumpkins, they're not yet fully grown. And Nzo went away. Guess what? The next morning, there were 2 pumpkins left. And Tsuro looked around and asked Nzo, do you have any idea what happened to my pumpkins? And Nzo said, no. Okay. Next morning, how many pumpkins left? 1. So do you know what happened to my pumpkins? No idea. We all know that. We've told that white lie, haven't we? So Tsuro is looking and thinking, I better act here. So Tsuro, dead of night, goes in, comes up with the pumpkin, goes inside and closes the pumpkin. And then Nzo comes and gobbles up the pumpkin. And I need a pop song. Who's going to sing a pop song? Who's the brave one? So the last minute of the story, we and I are going to help each other. So gobbles up this pumpkin and goes home and tries to lie down and just hears.
Thank you, Mr. DJ. Thank you.
What on earth is going on? I better check outside, there must be someone outside. Looking outside, nobody's there, but
thank you, Mr. DJ.
Maybe it's in those bushes. No one here, but
Thank you.
Let's give a big hand to me. Okay, I'm just playing, being playful. But that story, it makes me think a lot about what is happening now in this post-colonial era we're in. It feels like there's an elephant that swallowed a rather big pumpkin. made up of many pieces of the world. And that elephant is walking around with
Thank you, Mr. DJ. Thank you, Mr. DJ, for playing my song. Ooh, thank you, I've been waiting so long.